In this lecture, we will look at the remaining disorder, that is bipolar disorders, some causes of depressive disorders, and effective treatments that has been developed to treat mood-related disorders, including major depressive disorders and other bipolar disorder as well. Now imagine a friend of yours is currently completing a chemical formula that he knows will cure cancer. Shortly after, he had submitted a book to a publisher and was sure that it would become a bestseller. For several weeks prior to this, he was bedridden, morose, had no energy, and lacked any spontaneity. He never left his bed and had to be cared for by his family. Now, if you have to diagnose your friend, what would be the diagnosis? Now, based on major depressive episode and manic and hypomanic episode, this may sound more like rapid cycling specifier and also probably bipolar disorder 2, because his manic episode is not as severe as it deemed impairment in his life. What is severe in his case is more like he had more depressive symptoms that made him distressed and impaired. Now, those are two terms that I frequently refer to when I talk about psychological disorders, because it helps us to differentiate whether a particular condition is a problematic. Just having sadness and not going out, not talking much, not engaging social activity does not lead to depression, does not lead to a diagnosis. It should be tested for all those symptom criteria, especially the symptom that is affecting the person in occupation, social, and relationships. And also it's making person suffer to the point that every day, almost every day and all day, the person is abstaining from all the activities that he or she used to enjoy. Now, when you say bipolar disorder 1, again, my purpose to you is that we're trying to differentiate. Again, we're trying to identify the prototypical symptoms that most people would show in a given disorder. And in bipolar disorder, we talked about episodes. Recall what are the symptoms for depressive episode and manic episode. Now, we know that in bipolar disorder, again, one caution here I would take about bipolar is do not use this term loosely. Do not refer to people, those who have a normal mood swing. The person is happy at one time and again sad in the other time as bipolar. Because when you say bipolar, it is a diagnosis and it's a very distressing and impairing condition. If somebody is just normally happy and sad, that's normal. But if you meet the criteria, like you had either depressed mood or lack of interest plus 4 additional symptoms for about 2 weeks time, that is one episode, 5 symptoms, right? 5 symptoms for 2 weeks time, and the person is experiencing depressive episode. And you have 4 to 5 symptoms from manic symptom list, and you have this fleet of ideas, grandiosity, lack of sleep, constantly taking risky behaviors in financial and sexual activities, and the symptoms last about 7 days. That symptom lasts about 7 days. If the symptom didn't last for 7 days, the person was hospitalized because it was causing distress to the person. So even without 7 days, with the symptom, if the person needed to be hospitalized, then we call that is manic episode. And the person could alternate and rapidly cycle through these 2 episodes. Within 9 months time, the person could experience multiple depressive episode and manic episode. In a life course, the number of episodes people could have is 2 to 3 depressive episodes. So that is dangerous, right? The person continues to go back and forth in these episodes, then we know it is bipolar disorder. One clear distinction in bipolar disorder 1 is that there must be an episode of manic episode. If there is only major depressive episode, we know the diagnosis would be MDD. What if the person does not have these manic symptoms to the point it is impairing him? Now, in those situations, we look for there is major depressive episode, okay. The next one is there should be at least one hypomanic episode. And when you have hypomanic episode, the symptoms are identical to those for a manic episode if you look at DSM-5. But there is only minimal duration of 4 days in manic episode. And even though these episodes represents a very definite change in functioning, the person seems to be acting differently, but the symptoms are not severe enough to cause marked social or occupational impairment. So the person is experiencing hypomanic episode, he or she would not be impaired by those symptoms, nor the person need to be hospitalized. So that's what makes it distinct from bipolar disorder 1. Bipolar disorder 2 do have manic symptoms. It's a milder, not debilitating, not impairing, nor hospitalizing. And there are also no psychotic features, which includes delusion and hallucination. So that is considered bipolar disorder 2. And just to make sure that the person has never had a manic episode in the course of the disorder, right? So that's what you want to be very careful. Now, when you think that if hypomania is not impairing, then why do we need a diagnosis like this, bipolar disorder 2? Well, the problem is the symptom of depression is so unpredictable that could lead to frequent alternation between period of hypomania and depression. And that leads to distress and impairment in the person's life. I'm going to repeat that. So why do we need bipolar disorder 2 if hypomania is not distressing or impairing? Well, the person will alternate between hypomania and depression so often, it will be hard to predict what the person is going to do. And there's a more chance of developing into mania when person is experiencing hypomanic episode. So that's why, and the more distressing part or impairing part comes from depression and the constant switch back and forth, not particularly by hypomanic episode. And there's another term here worth noticing, which is cyclothymic disorder. Now, this is a chronic version of bipolar disorder. And again, in chronic cyclothymic disorder, there is an alternation between period of mild depressive symptoms. Now, keep in mind, depressive symptoms and mild hypomanic symptoms. There is no episode of major depression or hypomanic or manic episode is present. Now, the person has a persistent symptoms of depression and possibly symptoms of mania, but it never turned into an episode, which means the symptom lasted for a few days but not 2 weeks, or the symptoms are milder, not to the point it would cause many impairment and distress, and person may have symptoms of mania but didn't last for 7 days nor hospitalized. Person had symptom of hypomania, didn't last for 4 days, or it was not severe enough. However, the problem here is these symptoms, even in the milder version, will last for about 2 years. And the person is never free from symptoms for more than 2 months. Now, if you remember, we talked about persistent depressive disorder, double depression, right? Now, when you look at them, this is the bipolar version of PDD, persistent depressive disorder. In persistent depressive disorder, we saw that the person had major depressive symptoms for quite a long time, 2 years. And sometime there could be presence of both, right? That's what we call double depression. However, cyclothymic disorder is somewhat less severe in compared to even PDD or double depression, because here you have less severe symptoms from depression and hypomanic symptoms, but never turned into an episode. Symptom lasts for a very long time. Now that concludes the types of depressive disorders or mood disorders that we've been talking, and I'm assuming it gave you an idea when you think about different individual experiencing different symptoms. What we look at is what makes each disorder unique from one another. Only depressive episode leads to major depressive disorder. When there is depression that is lasting about 2 years without major depression, that would be persistent depressive disorder. If there is major depression and continue to experience continuous sadness for about 2 years, then we call it double depression. And if the person has manic and depressive episode, we call that bipolar disorder 1. If the person has hypomanic and depressive episode, then we call bipolar disorder 2. And if person has symptoms of hypomania and depression but no episode, then we call that cyclothymic. Now that's what I want you to be very familiar with. I want to have that clear understanding what are that unique or prototypical symptoms of each disorder. And also keep in mind that people who have been experiencing cyclothymic disorder, their chance of developing into bipolar disorder 1 or 2 is about 33 to 50%. So if you continue to experience these symptoms at some point, let's say 5 out of 10 people would experience or turn into bipolar disorder 1 or 2. So those information should help you to identify those symptoms, know those symptoms, and maybe find some help to those individuals that is appropriate. Let me ask you a question here. Now, we did talk about the depressive symptoms that is unique to children and adolescents. We saw a couple examples that baby blue does exist in children, and they do show symptoms of depression as early as 3 months. However, we noticed that prepubertal children may not experience the full symptoms of depression and definitely no mania. Now, bipolar disorder in children is often misdiagnosed as attention deficit hyperactivity disorder, and perhaps that's why DSM-5 introduced this new disorder of disruptive mood dysregulation disorder. Now, disruptive mood dysregulation disorder is a new diagnosis that allows to reduce number of misdiagnoses with ADHD, right? And children during their prepubertal period, they may not have that many diagnoses, but there are sometimes individuals, the younger children are diagnosed, but I would definitely examine if they are meeting all the symptoms that is necessary. And young children typically don't show those mania or bipolar symptoms. And when you say bipolar symptoms, the absence of mania is there. And when they turn into adolescence, then that's where the increased number of disorder. The children started to showing symptoms of major depression and also sometime mania. Now, depression rate in adolescents appear to be about the same as adults, and major depressive disorder in adolescent is largely a female disorder. That means more female are diagnosed with major depression in adolescents than males. And rate of attempts suicide does not change during adolescence. Adolescents with bipolar disorder may become aggressive, impulsive, sexually provocative, and accident prone behaviors you see more frequently in their behavior. Now, when you compare, the lifetime prevalence worldwide for major depression is 16%. That number goes up by almost more than double when you look at elderly individual, because they do have about 14 to 42% possibility to be diagnosed with depression. And one interesting fact there is that they may also have another disorder from anxiety related disorders. One thing that changed in elderly individuals is that the imbalance between gender, male and female, seems to reduce after 65 years. Now, the prevalence of depression is almost equal among elderly individuals, right? And being depressed is doubling the risk of death in early patients who had a stroke or heart disease. Now, that's like another scary part. And people, those who have diagnosis of depression, any of those mood disorder, they increase the chance of dying sooner by double. How about the sex differences? Well, females are twice as likely to have major depression. And bipolar disorder with mania or hypomania seem to be equally affecting males and females. And women more likely to experience rapid cycling and also depressive period for a longer time. You might wonder why there is such a difference between major depression in male and female. Well, we need to look at how those individuals are raised, culturally, how you are asked to express your emotions. And due to those reasons, females seem to have better vocabulary about emotions. They're more likely to seek help when they are experiencing emotional disturbances, versus male, even they have those symptoms, depending on what culture you're talking about, the expression of those symptoms might vary. The other important part in cross-cultural studies is that some culture more likely to express depression as a somatic concern, and they may complain about physical ailments, physical pains and difficulties, rather than identifying them as psychological problem. And in my experience talking about these depression, I do notice that even in our school student population, they do report that their family culture and their cultural background, family custom doesn't allow to identify themselves with psychological problems like depression. And the other interesting fact is that what about people, especially male, those who suffer from depression and are not diagnosed? If you look at the suicide rate, people, those who attempted and successfully, or at least kill themselves, that's the very clear term, attempted and killed themselves by suicide, died by suicide, you see more male than female, even though we see that people, those who are diagnosed with depression, is more female. So those are important facts to keep in mind. One more thing about culture is that when you look at Native Americans, they seem to have 4 times more likely to diagnose with depression or have depression when you compare to the general population. Now, let's take a look at some theories that explain how this depression manifests. And again, we go back to biological and psychological model. When you say biological model, biological explanation, we know people can inherit some genetic vulnerabilities to depression. And psychological factor, it could be triggered by stressful life events and your response to neuroticism, right? You are extremely prone to react with strong negative responses and running away from coping skills, like biological vulnerabilities. Here you see overactive neurobiological response to stress. Some individuals have that tendency. And psychological factor, how do you process information? What kind of coping skill do your society or your family culture teaches you? And one interesting fact here is social support. And do you receive necessary social support, or do you seem to be isolated because you complain about lack of sleep, lack of energy, lack of appetite? How do you perceive that? That could lead to develop a full-blown depression. And one interesting fact I was sharing in my class yesterday, that CSU system, now not just our CSUSP, but the CSU system reported that 11% of student population has accessed or used the resources like CAPS, Counseling and Psychological Service for Students. And when you look at our student, that is from CSUSB, we only have about 7%. 7% of use. That means if you take 100 people who have some type of psychological problem in our school, only 7 people went to CAPS and sought help. That's scary. Why? There's so many factors we can talk about. It could be how they perceive their problem, their fear of stigmatization, right? And people do suffer from depression. Even if you compare this with general population, there's quite a few more. This is like only half of the general population, right? There's about 14% people could develop depression. And the cognitive aspect is there is quite a few concepts, like information processing bias. You have memory bias. You tend to self-blame a lot, and you have attention bias. You tend to focus on things that is going wrong rather than overall happenings. And people do carry this core belief about self and others. We'll see when you look at theories, different theoretical explanation. Well, there you see that people carry, I am unlovable, nobody cares about me. Those kind of belief can contribute to exacerbate your symptoms of depression. Imagine you have genetic vulnerability. If you remember diathesis stress model, when you look at diathesis stress model, let's say you inherited some genes that makes you vulnerable to depression, and you're dealing with stress, and your cognitive style is more negative. You're more look at the mishappening in life than overall picture. That will definitely lead to developing depression. And from studies like twin family studies, they found that if person has a relative who also has been diagnosed with mood disorder, those individuals are more likely to develop mood disorder as well. And relative of bipolar disorder seems to have at least more than likely to develop one mood disorder, whether it is depressive disorder or bipolar disorder. And in twin studies, they looked at biological causes of mood disorder, and they found if one of a set of twins has a mood disorder, the probability that the other twin will also have a mood disorder is by 66%, concluding that evidence suggesting that mood disorders are familial and can reflect underlying genetic vulnerabilities. And studies are now beginning to identify a small group of genes that can contribute to genetic vulnerability to some type of depression. And that genetic contribution to depression falls between the range of 40% for female and 20% for male. Now again, it's not like 80 or 90%. The chances of developing mood disorder is, again, slightly lower than what people would say. You have family history of depression, you are like 100% going to develop mood disorder. That is not the case. That's what diathesis. You have this vulnerability, but how do you lead your life? The stress part, things that happen around you, coping skills that you have, cognitive processing you have developed, those matter as well. And genetic factors contribute not only for depression but also anxiety as well. Now, if you look at these twin studies, they seem to have 2 to 3 times more likely to present those mood disorder, because in general we have 20 to 40%. In twin studies we found 66% that both identical twins are, if one set of twin has depression or mood related disorder, the other member of that twin is about 66% vulnerability rate. And they also compared with fraternal twins versus identical twins, and they found this is more true about identical twins. And this heritability rate is somewhat different, right? You're not gonna develop depression. That's why sometimes when I think of mood disorders or any psychological disorder, we all have some vulnerability to some disorder, depending on how we lead our life, what kind of coping skills we develop. That will determine whether we will be suffering from one of those conditions. Now, looking a little more detail, current research into neurotransmitter system has produced that the permissive hypothesis, which means when serotonin levels are low. Now, serotonin has to do with sleep and mood regulation. Other neurotransmitter systems become dysregulated and contribute to irregularities, right? And we don't know exactly if this is 100%. It's just a hypothesis. Now, serotonin is such a crucial neurotransmitter, and serotonin regulates other neurotransmitters like norepinephrine and dopamine. And when you see that people have low level of serotonin, that's where permissive hypothesis come into play. The low serotonin permits other neurotransmitters to vary more widely and increasing vulnerability of mood disorders. And when you look at other factors like the endocrine system, you do notice that the suppression of neurogenesis in hippocampus is because of the connection between high stress hormone and depression. So those who are chronically stressed, they seem to suffer from neurogenesis. That means there are some genes that's supposed to be regenerated in a way, not all of them. Now that's like only in hippocampus you see that, and when there is a suppression of neurogenesis, that could lead to high level of that could be due to high level of stress hormone and extra activity in endocrine system. Now, low hippocampal volume can precede and contribute to the onset of depression. Now, that's where you see that, when you try to look at neurogenesis, that means the production of neurons in hippocampus, if you have low level of neurons in that system, you're more than likely to develop depression. And when you have this elevated cortisol, constantly stressed, that would lead to decrease in neurogenesis in hippocampus and making new neurons impossible, or production of new neurons turn into some kind of struggle. I think I'm finding a proper term here. Well, how about sleep disturbance? Sleep disturbance could be the hallmark of any disorder, including mood disorders. People with depression have quicker and more intense rapid eye movement sleep and less slow wave deep sleep. Now, when people are sleep deprived, they may temporarily improve depressive symptoms in bipolar patient. Why? That seems to be one case, right? There is more rapid eye movement sleep and slow wave sleep is less often. And when you look at these individuals, they tend to enter rapid REM sleep, right? Rapid eye movement sleep more quickly, and they also experience intense rapid eye movement sleep, and they also show delayed slow wave sleep, non-REM sleep. That's another term, non-REM sleep. Now, an interesting finding, isn't it? So when you look at people with depression, they seem to have some type of sleep disturbance as well. Now, how about psychological factors besides these biological aspects? Biological dimension could be pretty broad. Just to keep it short, the context of life event as well as its meaning to the individual is more important than the nature of the event itself. What does that mean is, when you look at an incident, the incident is not that important, but what do you make out of that is more important. So an individual's current mood state might distort their early memories of stressful life events, and that can precipitate depression. Now, people, those who are experiencing depression, they tend to, again, have this cognitive bias. And these stressful life events, they tend to remember more often. And one of the strong mechanism of depression is rumination. Rumination, because they tend to take some stressful life events and they tend to dwell, not just live, dwell in those stressful life events. And stress is strongly related to mood disorder because they tend to respond very poorly in treatments and they take longer time. People with a higher level of stress take longer time to overcome depression. Even the remission takes longer for them. And when you look at genetic and environmental gene and environment correlation studies, they found that people who are vulnerable to depression might be more likely to enter situations that will lead to stress, and that could develop into depression. So the relationship between depression, stress, and mood disorders, including bipolar and major depression, is very strong. The other factor here, learned helplessness. This is introduced by Martin Seligman, a theory that people become anxious and depressed because they believe that they have no control over the stress in their lives, and they tend to develop this sense of helplessness. And this is a crucial factor when you talk about depression, because when you think you have no control, you start to perceiving that your life is going out of your hand, and that could lead to decreased attempt to improve your own situation, right? You tell yourself, things that happening around me is out of my control and I can't do much, and they may not demonstrate any attempt or coping skill to overcome depression. That could be a risk factor for depression. And from cognitive vulnerabilities, if you look at internal attribution, things that happens to you. Now, we all know things that happen around us, including yourself or others or in the world. For example, I don't want to blame myself for the conflict between Ukraine and Russia. I don't want to blame myself for my even like immediate family members, like my parents' accident. I don't want to blame myself for my friend's surgery, so on. And I think I shared with you that I don't want to blame myself. I did think about it, but it just lasts for a short time. That my friend who died recently, it sounded like he had some suicidal thoughts, and I did think about, could I have done anything to help him? Well, I think about it, but I don't think I dwelled in it. So people, those who have this internal attribution with negative outcomes, who constantly blame themselves, that is one type of cognitive vulnerability for depression. And stable attribution could be believing that future negative outcome will be your fault. Now, if I were to be depressed and if someone else dies or someone else might die, that thinking, if I blame myself for the future happenings, the negative outcome in the future, that would lead to stable. It's because of belief that doesn't change easily. And global attribution, believing that negative events will disrupt many life activities. Well, we do worry about the Russia and Ukraine conflict, but that should not lead you to believe that everything in your life will be jeopardized, things will go out of control. We do take care of necessary steps to cope with those fear and try to overcome them. So these three dimensions, these dimensions of self, others, and world, contribute to sense of hopelessness, sense of that helplessness. And negative coping style, people, those who are depressed, tend to engage in cognitive error, starting from information processing bias. They only choose certain information that is negative, memory bias, attention bias, and leading to interpret with strong error we call cognitive distortion, and also that stem from core belief. Now, when you look at this negative cognitive error, this whole process we call confirmation bias. Confirmation bias, not all the way to up to here. So confirmation bias, why? Well, what you're trying to do is to find evidence to prove what you believe is true and ignore the evidence that shows that you are incorrect, right? Your tendency to interpret life events negatively starts with this cognitive bias. It's very fascinating when you look at people, it was my fault, it was me who should have done something else, I failed the class, that I will never succeed in life. Those are cognitive distortions. And when you look at these cognitive distortions, some examples might help, like arbitrary inferences, overemphasizing the negative aspect of a mixed situation. Now, there could be many reasons for Ukraine and Russia conflict. For my example, my friend's death. But I'm making a lot of, overemphasizing that negative aspect that could have led to my friend's death. Let's say I was only thinking about missing him. He was supposed to visit me and I didn't see him. If I just focus on that one particular incident, his visit to my house, that could be arbitrary inference. There could be many other factors: his health, his doctor visit, his health hygiene, his other family issues, his other relationship issues. I'm not looking at them. I'm just looking at one single incident. That's arbitrary inference. And overgeneralization could be negatives applied to all situations. For instance, a student who has been doing very well in my class receives a minor critical comment on an essay, and she wrote part of an exam, and she thinks this is terrible, I'm probably going to fail the course. This type of cognitive error we call overgeneralizing. Humans are prone to errors. We are not immune to mistakes. We do make mistakes, and that mistake does not mean it is reflective of the entire life. Catastrophizing, that's another cognitive distortion. One single event, you think that I'm doomed. I'm never going to graduate. I will never make anything right. And sometimes mind reading. People, especially in anxiety disorder, we talk that I know those people are laughing at me because I can sense it, so on. So you're mind reading. That's another cognitive distortion. So these cognitive distortion comes from these biases, and you interpret. That's where cognitive distortion happens. You interpret because of your core belief. You believe that I am not lovable, or I am unlovable, I am not safe. So if you have these core beliefs, things happen around you will be interpreted based on those core beliefs, and you constantly lead to cognitive distortion. One thing I want to add here is that when you have cognitive distortion, you are not 100% wrong, or you are not 100% right either. So I should have the nor you're 100% right, neither you're 100% right, nor you are 100% wrong, right? Your interpretation could be 10% correct, but there is 90% that you ignored. That's what happens in cognitive error. People tend to ignore that 90% and focus on this self-blame schema. That's the term that Aaron Beck used. It's an individual who are depressed, who are experiencing depression. They feel personally responsible for bad things that happens around them. And that comes from this cognitive triad: self, the world, and the future. And also this negative self-evaluation schema. People with depression believe that they can never do anything correct. And when you overgeneralize minor error, that just magnified something that happens around you is always important. Sometimes just matter of simple happening, you might need to just ignore it. That's crucial to keep in mind. Now, if you remember the chain of this like domino effect, you start to see errors in your information processing that lead to more and more errors, lead to developing strong negative attribution about yourself, and also end up developing depression. Now, in terms of marital relationship and social support, well, marital dissatisfaction is strongly related to depression. And this is particularly strong for male. And social support, we know that's like one leading factor, one protecting factor that we could have. When you don't have them, lack of social support does increase the onset of depression, and it also explains that substantial social support can predict recovery from depression faster. And how you are acculturated, what kind of family surrounding do you have, that matters as well, because then we tend to lose sense of control and sense of hope, when you don't have social support, and that also tend to increase self-blame that could lead to depression. And if you look at if you look at this chart, there's a male female difference. The possible reason that the higher rates of depression found in women related to disadvantage experienced by women in the United States, such as discrimination and poverty, abuse and sexual harassment, pay disparity, all this conflict, even after hundreds of years that we became such a prospering country. So those things are important to consider. Let me ask you a question, then we talk about treatment. Now, when you talk about treatment for mood disorders, definitely we will look at medication, right? And one of the most commonly used medication for quite a few mood-related disorders is SSRI, specific serotonin reuptake inhibitor. Now, when these drugs are administered, just like the word says, it will prevent serotonin from reuptaking process. And when you reduce removal of serotonin particles from your synaptic cleft, the gap between neurons, it will allow to regulate other hormones, other neurotransmitters as well, that include the norepinephrine and dopamine. Now, they are regulated better. However, like Prozac is the most commonly used SSRI, and that could also increase the risk of individuals attempting suicide or killing themselves by suicide, especially in teenagers. There are a lot of side effects that you see. So we do need to think about using SSRI as a choice of drug for depression, because it's not free from side effects. And especially if you are pregnant, it could increase the risk of birth complication. So that's one thing to keep in mind. Personally, I am more pro for psychotherapy than drugs, but there are options for individuals who are suffering, who are going through depression. And tricyclic, that includes the antidepressant medication, also the class of drug that is still need to study more, and they're trying to find out more about the mechanism of these drugs. Tricyclic antidepressant, it blocks reuptake of norepinephrine and other neurotransmitters, but it still has some negative side effect, commonly known as drowsiness, weight gain, sexual dysfunction, and so on. And if you administer these in children under 14, that could lead to death. So if you discontinue these drugs like tricyclic antidepressant, well, the problem persists. It could the person could relapse in depression, and overdosing is extremely dangerous. It could be lethal as well. Now, the other drug that we need to look at here is MOA inhibitor, monoamine oxidase inhibitor. Now this drug works slightly different. What it does is, if you have a little bit of knowledge of neurotransmitters, when there is neurotransmitters floating around, there are two things that could happen. These neurotransmitters either taken back to presynapses, we call reuptake process, or if these neurotransmitters are little outdated, little old, overused, there is enzyme like spelled like ENZYME, enzyme. These are called oxidase. They come out and destroy these neurotransmitter and excrete from the body. Now, what does this MOA inhibitor does? It will block these enzyme. That means the neurotransmitter that is floating in your synaptic cleft will remain floating for a while, and it continue to stimulate your post-synapses and continue to change your physical and psychological experience. So that could be one way to avoid number of neurotransmitter present in your synaptic cleft, and particularly this MOA inhibitor will work on serotonin and norepinephrine. But there is definitely danger to combine these drugs with like alcohol, beer, red wine, and certain food like cheese. And sometimes people have certain dietary restriction. People might not think about it. Combining these drugs with cold medicine, that could be dangerous. So just be mindful of that. The one more drug that I didn't mention here is lithium. That's another psychoactive drug that also is used to treat bipolar disorder. That's a choice of treatment for bipolar disorder. And it is also considered a mood stabilizer because it treats depression and mania, depressive and manic symptoms. It also helps to prevent manic episode. But again, there is a problem. If you overdose, it could turn into a lethal response. And people, like if 100 people takes these drugs, only 50 of them seem to show improvement. And why lithium works is not fully understood, but there definitely is a problem. Toxicity is there. It can also lead to other thyroid functioning issues. So you want to be careful when we think about using any of these drugs. Now let's turn to psychotherapy, my favorite. When we talk about depression and intervention, there is no way we would talk of these terms without looking at cognitive behavior therapy and interpersonal psychotherapy. Cognitive behavior therapy, as you see, the underlying cause for depression is cognitive error, and cognitive behavior therapy try to address that issue probably by identifying those faulty assumptions about life, addressing cognitive distortions, challenging some of those core beliefs that where people try to focus too much on negative, right? The confirmation bias. So we know when we say cognitive behavior therapy, we will be addressing how to change people's thinking by Socratic questioning, cognitive restructuring, and also partially when it says behavior, my pen is not writing where I want, behavior, we will also look at behavioral activation. Now when you say behavioral activation, we're talking about how individual those who are extremely lethargic, if you think of like the specifiers like catatonic symptoms or atypical symptoms, we want to see if we can change their behavior so we can bring them into some type of behavioral activities, right? So scheduled valued activities. And the other important CBT, the next evolution is acceptance and commitment therapy, ACT. That's another term. When you look at ACT, they try to emphasize, challenge people actually by identifying values of their life and trying to find out, would you rather ignore your life by letting go of something that you find meaningful, or continue to live your life as it was by identifying those values despite the distress that is caused by depression. So cognitive behavior therapy, in short, try to challenge those biases: information processing bias, attention and memory bias. Then try to change your cognitive distortion, where they ask for evidence for and against your belief, your interpretation about life, about yourself, about others, and try to see if it can bring your awareness about there's more than what you think. Cognitive distortion is only one possible happening when you compare it to many other possibilities. Interpersonal psychotherapy, it focuses on treatment that sometime related to someone's death. They call complicated bereavement. They might have strong attachment with the person, therefore they are unable to move on. They may be in a struggle with their significant others, because when somebody is in a role dispute, that's the term they use, people could experience depression, or the person may have gone through some other important life change. We call, in IPT, we call role transition. And the other part could come from relatively infrequent absence of any of these. There is the default focus on interpersonal deficit, a confusing term that really means that the absence of a current life event. You are not present with those activities. And they try to teach social skills and try to overcome those interpersonal disputes and try to improve overall relationship, which also seem to work really well for depression. And one more thing here you should be mindful of is that when we talk about depression, the biggest problem is relapse. And not many psychotherapy has focused on preventing relapse, but CBT has done that. There is a specific training, specific protocol for depression in CBT when they talk about relapse prevention, mindfulness-based relapse prevention, where they try to help people not to live in the past and ruminate too much, but focus on what's happening in the present moment. That is mindfulness-based, where they train individual to practice mindfulness, to keep their attention in the present moment so they don't continue to experience depressive episodes. And there's another cognitive behavior therapy, mindfulness-based cognitive behavior therapy, MCBT, and there are other like ACT, where they focus on values and meaning. So these treatments work really well. And in research, they know when you use cognitive behavior therapy, it could be a standalone treatment. It could also be a strong intervention to prevent relapse. So in sum, that when you think about treating depression, medication does help. However, lithium, that is the first line of defense for bipolar disorder. Psychotherapy could be really useful when we think about helping people to overcome relationship issues, role deficit, cognitive errors, and that can also have no side effect at all. So if somebody is very much pro to or seeking medication, I think the best suggestion is you must combine. It's better to combine medication with psychotherapy, where medication can help you with some neurological alleviation. It try to help serotonin level maintained, and eventually that lead to norepinephrine and dopamine regulated better. In the same time, you also try to use psychotherapy, where you can address interpersonal conflict, occupational issues, behavioral activation, and so on. And that could produce long-lasting effect. Now, one more thing that I want to address here is suicide. When you say suicide, it's a very debilitating situation, and suicide is real. Recent evidence indicated the higher level of suicide in patients with bipolar disorder than those who those who have a rapid cycling pattern. Those people who alternate between depressive and manic episode or depressive and hypomanic episode, they tend to attempt suicide or die by suicide more often. And when you look at teenagers, suicide is the third leading cause of death after auto accident, or homicides. And suicide is also often associated with psychological disorders, especially depression. And you look at the gender difference, there's a fascinating evidence from research. Male complete more suicide than female. Female do attempt more often than male. This disparity could be because that male use more lethal methods in compared to female. And sometimes many cultural aspect is important to consider, right? Like certain culture consider that suicide is seen as an honorable solution to problem. If you have seen movies, I don't know if this is still true for the Japanese samurai tradition, right? When they fail in certain tasks, suicide is considered an honorable way to end the problem. And also in terms of psychological problem, suicidal behavior is often seen as impulsive part of personality disorder, like borderline personality disorder. Now, when you talk about suicide, there are some myths that I do want to add in this lecture. If you ask, for example, asking a person about suicide will encourage the person to attempt suicide. Not quite. It's the opposite is the truth. Asking someone directly about the suicide or suicidal feeling will often lower their anxiety level and act as a deterrent. Your openness and concern in asking about suicide will allow the person experiencing pain to talk about their challenges. This may also allow the person with suicidal thoughts to feel less lonely or isolated and perhaps a bit relieved. So it's not always the case. You cannot put that thought in their head. If it is there, it's already there happening without your awareness. Once a person is considering suicide, there is nothing that you can do. That's a big myth. That is not true. Most suicide crises are time limited. People attempt suicide for generally looking for a solution or an escape. We know that. And they generally do not see any other solutions. That's like their limited cognitive view, right? They have this error in thinking, everything is my fault. So as psychology students and as psychology learners, we do play a significant role in helping individuals who are suicidal by providing hope, providing support, and also helping them to develop a plan to start feeling better. That's one important role. And I'm inspired about these ideas because of I work with mental health first aid. And another possible suicide myth could be a person who attempts suicide will always be suicidal. Now that is a big myth, because you do feel suicidal when you are experiencing depression or you feel like no way out. But if you give them proper help, proper assistance, they will never be suicidal again, depending on what kind of help they received, right? And improvement following a suicide crisis means that the risk of suicide is over. That's another extreme thinking. Now, somebody who die by suicide do so within 3 months after the onset of a period of improvement, which means you might overcome. However, when you lose support, when you lose your important support from family, your coping skills, you may relapse in that idea as well. So just be mindful, and I will post an article on, I think, about 15 myths related to suicide. And these suicide signs could come in many forms. Sometimes people give you clue where they start to arrange their life better, they start to call everyone, they start to set a goal for themselves. It could come in many ways. And look at this, youth prevalent. The article will also give you some ideas. And here, second leading cause of death in college. 12% of college students consider suicide in a given year. That's a lot. If you take 10 people, there is at least one person entertain the idea of suicide. So please, if you get a chance, if somebody talks to you, I think my suggestion is at least ask. Or this is the magic word I can give you. Always tell them you are not alone. I am here to listen to you. I'm here to help you. Please feel free to talk to me. Some kind of phrases that you can use to give them hope that they are not alone. They don't need to fight this battle alone, and there are so many professional helps. And that goes back to what I mentioned about, using caps. It's so low in compared to our CSU system. We only use 7% of our students use caps. And please feel free to use those facilities anytime you feel you're dealing with a lot of stress. Do reach out to those help, and if needed, please reach out to me. You can definitely send me an email asking for help or asking to have a Zoom meeting so we can talk. I will be definitely helpful to guide you to some resources that would, it could be for yourself. That would be useful. It could be for yourself. It could be for someone else. So there are help. It's just a matter of trying them and bringing them into our awareness. And moving on with a little bit more, people, when they are, the nature of suicide, there's so many risk factors: biological, personality, some psychological disorders, environmental factors, and the way you process your information, and your other factors like your threshold, your ability to take those problems. And people, those who are suicidal, they tend to use alcohol more often. 1/4 of the people with suicidal ideation tend to abuse alcohol. Some other risk factors, but these aspects are important. And anytime you hear people talk about ending their life, they might say in a different ways. Please ask them, sit down and ask them, give them non-judgmental listening. Pay attention, and if you can't help, at least guide them to proper help where they can benefit from. And also watch for some of these ideas when you talk about suicide, because things that we see, like suicide has become such a fantasy talk in movies, right? And some research indicate that a people is more likely to attempt suicide after hearing about someone else has attempted suicide. So I don't like the word commit. I prefer to say die by suicide or attempted suicide or kill themselves. Why? Well, commit is related to crime. Commit is related to some type of like long-term uses. It doesn't need to be so. So when you hear that, and it could be encouraging to people, because in a way it's like somebody's modeling, right? So when you hear that, and not only the people, but if you watch movie, right, there it is glorified and it is romanticized in media, and people like to copycat those ideas, and that increased vulnerability when you have psychological disorder. So definitely you don't want to romanticize or glorify those kind of ideas. What you want to do is, and even like describing lethal methods, people trying, definitely seek professional help. If you don't have anybody, if you don't know who you should call, I can be one person, because I am trained as mental health first aider. I'm also trained as mental health first aid instructor. So if you need any resource, if you need any guidance for yourself or someone else, always reach out. It doesn't hurt. It does not hurt. It will definitely prevent further damage for your well-being. And thinking about these cognitive aspect, thinking about these possible treatments, there are a lot of helps available. And anytime you have concerns, please save this number in your phone. So this could be a lifesaver for someone. If you see something, do say something. And if you can't say anything, at least be there for the person. So in this long lecture video, I was planning to give you how these different mood disorders are disorders are connected, but also they have their unique features. And we look at some causes. We also talked about some treatment, and also in a way, I don't do this in other lectures, but I do want to encourage everyone to be mindful of your own well-being, of your mental well-being. And if anybody needed help, I am available. And if you need help, please do reach out to CAPS, because these incidents are happening everywhere around our life. So that's pretty much for now. Let me ask you a question in this remaining lecture.